Thank you for the kind invitation, and please do accept my apologies for not joining you in person. I've enjoyed meeting so many of you and making new friends, and I hope you'll invite me back so we can do this in person next year. My first talk is on restaging TURBT prior to definitive therapy with radical cystectomy. We've been looking at our data as part of a practice review to see if this is providing a useful decision tool. And I want to point out Justin Mayer, one of our outstanding medical students, and Dr. Jenna Bates, one of our residents, have put together a terrific data set to help sort this out, as well as conducting an extensive literature review. These are my disclosures, and none are relevant to the present talk. So there's been a nice study out of MD Anderson. Steve Culp did this when he was a fellow there, looking at risk factors for extravesical and occult metastatic disease, and they identified the six features that I've highlighted under higher risk of relapse, and they include a 3D mass on EUA, which would imply a T3 or T4 tumor, locally extensive disease, lymphovascular invasion, hydronephrosis, and then variant histology with either micropapillary tumor and small cell neuroendocrine cancer. And they used these to identify patients who were at low risk or high risk for both overall survival and cancer-specific survival. Not surprisingly, patients with any of these features were in the high-risk group and had worse outcomes. We took a look at our own data when Fritz von Rundstedt was a fellow here and published this a few years ago and found essentially identical findings. So our major society guidelines address the role of cross-sectional imaging, and it's very clear that this is part and parcel of working up patients with muscle-invasive bladder cancer, and the primary utility may be to identify patients with locally extensive disease or T3B disease, and though the accuracy of this is really variable depending upon what paper you read, and you can see it ranges from anywhere from 55 to 92%. So Lee and colleagues published an excellent review in the American Journal of Radiology and concluded that CT urography is quite useful for the detection of bladder cancer and perhaps is most useful for identifying patients with T3 and T4 tumors. In this small prospective series of patients with CT using a pre-specified protocol to optimize the detection of extravesical disease prior to cystectomy, there was actually a high degree of accuracy in predicting perivesical fat invasion. You can see some examples of this in the CT images on the top right. So MRI may actually be the sweet spot of cross-sectional imaging, and there's a number of nice studies that have addressed this, and I'll just highlight a few of them. So in this paper by Cornelissen et al., they reported a review of multiparametric MRI in 2020 and found a high sensitivity and specificity for differentiating between T1 or lower stage tumors versus T2 or higher. However, it did not appear to be useful for differentiating by T stage among muscle-invasive cancers. In this next paper, they reported a small series using conventional MRI in 27 patients undergoing radical or partial cystectomy and found a lack of consistency when correlating clinical and pathologic tumor stage with a small but significant number of patients that were over and under stage. There was no difference in accuracy when stratified by whether they received neoadjuvant chemotherapy, chemoradiation therapy, or neither of these. And then Schreier, using dynamic contrast enhanced MRI prior to chemotherapy for patients with unresectable or regional metastatic disease, reported a high degree of accuracy, sensitivity, and specificity in distinguishing responders versus non-responders. And here's just some examples of what you get with MRI. Particularly if you look at the top right, the clear delineation of the detrusor, the perivesical fat, and the disruption of the perivesical fat that you see with a locally advanced cancer. So we worked with a multidisciplinary group led by Valeria Panabianco in developing the analogy to the PIRAD system called VIRADS, or Vesicle Imaging Reporting and Data System. And so the figure on the right from this publication in European Urology describes VIRADS 1 through 5 that spans the spectrum of disease from papillary non-invasive to extravesical extension. And then in a recent application of this, Liu and colleagues reviewed 6 studies comprising over 1,000 patients reporting the VIRAD system on MRI. And the curves at the bottom show a high degree of sensitivity and specificity for VIRADS 3 on the left and Virad's 4 on the right, which correspond to non-muscle invasion and muscle invasion. So I think that MRI may really be the sweet spot for local So in this meta-analysis, which was done a number of years ago, it confirmed the utility of PET-CT, as I just showed in the previous case, for assessing detection of metastatic disease, though they concluded that it was not useful for assessing the primary tumor because of the tracer excretion in the collecting system. However, this more contemporary study looking at 37 patients from the University of Minnesota, this group asked the specific question about restaging patients following neoadjuvant chemotherapy and reported a high sensitivity and negative predictive value for pathologic complete response, which they defined as PT0 and PTS, although this was a small group of only 8 patients, but it did have a high negative predictive value for pathologic complete response. So what about exam under anesthesia? So we think that this is a really important component of the evaluation of the local extent of the primary tumor. This was described probably over 70 or 80 years ago, and you know it well. It's a patient with a 3D mass is most likely to have a T3 tumor, and you can also assess for fixation or extension out to the pelvic sidewall. So MD Anderson did a nice review of a very large number of patients collected over about 20 years, and EUA in conjunction with imaging had the highest percent of correct staging versus EUA alone or imaging alone. And EUA and imaging were the only factors predictive of PT3. They had a high specificity and a good negative predictive value that supported the utility of EUA and imaging to rule out PT3 as well. Though if you look at the area under the curve, this would be the red line here, there was only a modest improvement over imaging for the detection of locally advanced disease. So this is another nice study from MD Anderson of patients accrued over about a 16-year period, very large number of radical cystectomies with long median follow-up, and they had 157 patients who were clinical T0 after 2 or more TURBTs. About half of those patients have been treated with neoadjuvant chemotherapy, and about a third were PT0 at radical cystectomy, and among those 4 were pathologically node positive. So this is a table describing the pathologic outcomes and response to neoadjuvant chemotherapy. And if you look at the roughly quarter of the patients who, remember these were CT0, that ended up being muscle invasive bladder cancer, and a significant number of patients who ended up having extravesical disease or node positive disease, suggesting again some of the challenges with clinical stage T0. And they identified a number of preoperative predictors of pathologic T0 response. We've talked a little bit about this at the beginning of the talk. But essentially on logistic regression, there were no factors that predicted PT0, and so they concluded that complete removal of tumor at TURBT does not predict PT0 at cystectomy, and I believe they continued to do radical cystectomy in these patients and recommend that. So this is a great prospective single-arm trial from Fox Chase where they took 61 patients undergoing radical cystectomy and did what they describe as systematic endoscopic evaluation right before the cystectomy under anesthesia. So 31 of these patients, or half, were clinical T0, but half of these actually had residual disease, and a quarter of them had PT2 or greater. The negative predictive value of clinical T0 under these circumstances was only 48% for predicting pathologic T0, and they actually stopped the study because of futility. So what about Restaging after chemotherapy. Can we use the TURBT to determine the response to neoadjuvant chemotherapy, and is it accurate enough to be a predictor of complete response? So this group from Johns Hopkins retrospectively reviewed a large cohort of patients treated with NAC and assessed the post-NAC TURBT staging accuracy. So essentially, it was a poor indicator of response, as 32% were falsely downstaged when compared to pathologic staging, and 38% that were less than T2 on TURBT actually had muscle-invasive cancer with a negative predictive value of only 62%. And you can see these data presented in the box plots over here on the right. So in this study from UC Davis, they've asked a very similar question with 60 patients treated with neoadjuvant chemotherapy, 32 of which were clinical T0. These patients had a significantly higher rate of overall cancer-specific and overall survival, you can see highlighted in the red, but about a half of them recurred, 7 remained disease-free, but 4 required radical cystectomy, and 7 patients recurred with metastasis or were dead of disease. So this is a problem with restaging, even under the important scenario following neoadjuvant chemotherapy. So there's a cautionary tale that we learned from a SWOG trial that was conducted quite a while ago, SWOG 0219, and actually Primo Laura from UC Davis was the principal investigator. So they did neoadjuvant paclitaxel, carboplatin, and gemcitabine, and then restaged everybody and found about half of the patients were clinical T0, but everybody that went on to get a cystectomy, over half of those patients had persistent cancer at cystectomy, despite the fact that they were presumed to have a PT0 status. So all of these data in aggregate have called attention to the challenges of clinical staging, whether it be with or without neoadjuvant chemotherapy. So I like to say that it all starts with a high-quality TURBT and bimanual examination and anesthesia. This tells us a lot of useful information about clinical stage. It establishes histology, allows us to look for some of these high-risk features that Steve Culp and the group at MD Anderson described, gives us a sense about the depth of penetration. Complete resection isn't necessary when you're planning a cystectomy, though it's probably useful for patients undergoing chemoradiation therapy. I recommend doing site-directed biopsies to look at CIS and then also to sample the bladder neck and the urethra. And these are important for planning your urinary diversion. And this is just how we do the biopsies of the apical prostatic urethra. We take a loop resection at 5 and 7 o'clock adjacent to the verumontanum. This is where CIS lives in the prostatic ducts. And you can see the importance when you're planning an orthotopic neobladder in females, where roughly about a third of them may have cancer at the bladder neck and urethra, and those are not the patients that you want to do urethral preservation on. So we established quite a long time ago for a major research project that we have for proteogenomics, this clinical and banking workflow. And this is essentially what we've been doing for quite a long time. So we take patients who are candidates for neoadjuvant chemotherapy, and most of these patients are referred in from the outside, so they've already had a TURBT. We take them to the operating room and do this restaging evaluation. We get tumor for the tumor bank and blood and urine for liquid biopsy samples, and then they'll get neoadjuvant chemotherapy, or if they have locally advanced disease, chemotherapy for metastatic disease, and then we will restage them. Take them back to the operating room, repeat all of this. We'll oftentimes get additional samples for biobanking, and then they'll go on to get a radical cystectomy and a lymph node dissection. And we track all of this in a specimen tracking system called Open Specimen, and this is just a snapshot of what we have in the bank at this particular time. So this is the data that Justin and Jenna put together. And again, we were asking this question about the utility of all of this restaging. And the patients, I have to say, are quite accepting of this once you explain the perceived utility. So we had a decent-sized group of patients, 129, all with restaging TURBT prior to cystectomy. We compared patients who received neoadjuvant chemotherapy to those that did not. We had 53 that had NAC between their initial and restaging TURBT, and you can just see the consort diagram here on the right. This is unpublished data, so I would appreciate you respecting that. These are the data. So our overall upstaging rate for all 129 patients was 22.5%, or roughly a quarter of the patients. And there was no difference in upstaging between the NAC and the no-NAC groups. In the patients that were clinical T0 on RE-TURBT, there was no difference in the rate of absence of tumor on pathologic staging, or PT0, between NAC and no-NAC. And you can see that this was really a minority of the patients that were PT0 when we thought that they were clinical T0. And then in RE-TURBT in patients post-NAC who had non-muscle invasive bladder cancer as a predictor for the absence of muscle invasive disease, there was again no significant difference between NAC and neoadjuvant chemotherapy, with a negative predictive value of 69 and 67% respectively. And these are the data just represented in the box plots. This is the entire group here on the left. The middle the middle box plot is the neoadjuvant patients and the non-neoadjuvant patients. And you can see over here what many other people have shown, the significant upstaging in both clinical T0 as well as non-muscle invasive disease, and particularly the understaging rate with T1 tumors that you see here. And notably, all patients who were clinically node positive were ending up being pathologic T2 or greater following NAC and RE-TURBT. So those patients, regardless, really need to have a radical cystectomy and extensive node dissection. So in a little preview of my next talk on genomics, Yair Lotan from UT Southwestern organized a small multi-center study that we participated in to identify genomic predictors of upstaging. This was a collaboration with GenomeDX, who has a classifier that's built off the TCGA data. And we were asking a very specific question in patients with organ-confined cancers, either clinical T1, clinical T2, that went on to get cystectomy without neoadjuvant chemotherapy, so no intervening treatment. And we were asking a specific question about predictors of upstaging to locally advanced or metastatic disease. And what you can see here in Table 2, this is published in European Urology, that the luminal tumors, which generally make up about a quarter to a third of patients, had a lower rate of upstaging overall, including pathologic T3, T4, or node positive disease. And then in this table, you can see that it was an independent predictor of pathologic upstaging, in addition to smoking status and clinical stage T2 versus T1. And then when you looked at outcomes of cancer-specific mortality, the luminal tumors had better outcomes than non-luminal, and this is what we would expect from all the molecular data that have been reported by multiple groups looking at subtype. So in summary, advances in cross-sectional imaging with CT and MRI clearly have improved our ability to distinguish non-muscle invasive from muscle invasive disease, especially when combined with EUA. And the sweet spot may be actually in identifying patients who are more likely to have locally advanced disease with either T3 or T4. But there remains a persistent understaging rate in patients that are clinical T0, and I hope I've shown you this persists across multiple studies, and the numbers are very consistent. And so we and most other people continue to recommend definitive therapy with cystectomy or chemoradiation therapy in those patients who are CT0, regardless of whether they've received neoadjuvant chemotherapy or not. And I'm really excited about the kind of research that I described in that last slide with the subtype analysis. But all of this needs to be validated in prospective clinical trials, and I'll talk a little bit about that in my next talk on genomics. So thank you again. I appreciate it. And I hope to see you all next year in person.